collagen less elastic?
Joe.
No,
I got
just
that on
less in
camera.
general. They get thinner
Collagen.
unless they're having it injected.
Ejaculation.
They are in LA. You guys told you guys that you do this dizziness treatment where you have to lay someone back and hang their head back and they're trying to upside down, and that patients, you put them upside down, nothing moves. Oh,
Nice.
no, you have all of us now. Yeah, this one woman especially, like everything, nothing moves. Think you're supposed to like move a little when you go upside down?
Yeah.
You know, then I've had like male patients who was like in the waiting room like drawn on his eyebrows too.
Doing what?
Used black eyeliner to draw on his eyebrows. And it was like shedding everywhere.
John like Madonna.
He was there with like a woman who was like 40 years younger.
Nice.
And she sat in the waiting room putting makeup on like the entire 50 minutes.
Wow.
Did it help?
It's a great couple. I got him his dizziness better.
Oh.
Well, then you can put on your makeup.
Okay, so skin as we get older gets thinner and less elastic. And there's going to be slower turnover rate in the epidermis. So all of these are going to delay wound healing. Okay, because of the loss of collagen and elastin, there's also decreased tensile strength of wounds even after they've healed, which makes them susceptible to re-injury. And that's true of anyone, it's just more true once your skin is older. Okay, now as we get older, there's an increased likelihood that they have a secondary comorbidity, chronic condition. They're more prone to poor nutrition and hydration. A lot of elderly people get dehydrated easily because they stop drinking as much because they don't want to have to go to the restroom as much. They are more prone to urinary incontinence. So they stop drinking, they get dehydrated. So force water on all your patients.
Waterboard your patients.
Waterboard. Told you about the 100-year-old who would only drink Mountain Dew.
Oh, yeah.
And I had my Russian patient who would only drink vodka. He
Gee.
generally would not drink water in the clinic.
In the clinic?
Yeah, because we always offer water, and every time they're like, nope, just Mountain Dew, or nope, just vodka. That one. Okay, know this phrase, wound dehiscence. This is when basically a surgical wound bursts open and you can actually have a visceration. Okay, so a visceration is when you have protrusion of the underlying organs, most often the intestines. If there's an abdominal surgical wound, like the hernia, or they have some sort of other abdominal surgery, like. And remember, we have to teach them the proper way to cough. So if someone has a wound anywhere on the thorax, they have to brace with a pillow. They have to cough or sneeze. Fistula. Fistula means a hole. So this is when we would have tunneling or undermining. So undermining again occurs around a wound's edges. So you've got epithelium and then it curves under because there's no tissue underneath it. Tunneling is the whole channel and part of a wound. So again, the outermost layer is intact, but the under layer is not.
Yeah.
But one could kind of be created. So if there's any undermining and tunneling, the reason it's an issue is we actually need to make sure the underlying tissue heals before the over tissue. So what you do is you pack the wound. Okay, so you take, usually it's gauze strips, they make other sort of things as well, and you stuff it in the wound. Now you don't pack it too tightly, because if it's too tight, there's pressure, then you won't get any wound healing. But you fill it just enough so that the lower levels will start catching up with the upper levels. Okay, because otherwise the wound could completely close, and it looks like it's healed, but underneath it's not. And so then what you would do is you actually document the amount of packing material you use to fill the wound. Okay, so from this lecture, you should be able to list all of the functions of the skin. You have to know the different types of healing, so primary, secondary, and tertiary intention. You have to know all the layers of the skin and what structures are in each. And then be able to recognize what intrinsic and extrinsic factors might delay wound healing. Questions? Before we get to the real juicy stuff. Okay, so the three main things you're going to use to classify a wound or name a wound are its age, its depth, and its color. Okay, so we classify wounds as either acute or chronic. Almost all the wounds you're going to see are going to be chronic, but you'll see acute wounds post-surgery. And if the patient maybe falls in your clinic or just left your clinic and then fell in the street. So an acute wound is a new wound that occurs suddenly. It can heal in a timely, predictable manner. And most often you'll have wounds that heal by primary intention. Chronic can be a wound that develops over time, or it can be an acute wound where healing has slowed or stopped. Almost all of these wounds are healing by secondary intention, because there's been some sort of tissue loss. Okay, so I told you we have to know the different tissue types of the skin, because that's what we use to classify the wounds. So we can title wounds by being partial thickness or full thickness. So partial thickness wounds only ever involve the epidermis and maybe part of the dermis. Full thickness wounds extend all the way through the epidermis and the dermis and will expose subcutaneous tissue. Okay, so partial thickness, epidermis, and partial dermis. Full thickness, all of the epidermis and dermis, exposing subcutaneous tissue. Okay, wound color. It's either going to be red, yellow, or black. Red wounds are good wounds. You want them to be red. Red is called granulation tissue, and it looks like beef. Okay, but red is a good
Got you with
sign.
another one.
Red wound bed is a happy wound bed.
Joe, I got you with another one from yesterday.
If there's any slough, which I said is wet and yellow, it's soft necrotic tissue. So it's usually leftover fibrin from the healing process and will be around the wound bed. So the wound bed is mostly red with granulation. but there's a little bit of slough on one part, you classify the wound as yellow. So if there's any yellow, you call it yellow. Yellow is slough, which is soft necrotic tissue. And we don't want it to stay there because not only does it block oxygen, it is a medium for bacterial growth because it's very wet. Black means necrosis. It is referred to as eschar. And if there's eschar, you remove it unless it is an arterial wound, then you don't touch it. Okay, eschar is dead tissue. It's often very dry. So you always classify the wound according to the least healthy color. If there's any black, it's black. If there's any yellow and black, it's still black. If yellow and red, it's yellow. It's just red, then it's red. White will only be the peri wound. Otherwise, it's just a different color of Okay, so red means things are going well. You gotta keep it covered, you gotta keep it moist, and protect it from trauma. Yellow means things are okay, but you gotta remove the yellow. Black means debride it, get rid of it, unless there is inadequate blood supply. Never remove eschar from an arterial ulcer. So, what we know about arterial insufficiency, why would we not remove the dead tissue? Might not expose the artery, but think about what's happening physiologically in arterial insufficiency and why would we not remove dead tissue? Because it's not going to heal. Nothing else is going to replace it. So you're just going to expose the underlying tissue that may not be dead. And no new tissue is ever going to grow because there's no blood supply to make it happen. Okay, so if you don't have a blood supply, wounds can't heal. So you're going to keep the dead tissue there because it's actually serving as protection to the underlying tissue that may still be intact. So that's why you got to get treated medically right away to try to get circulation back to that area. Otherwise, more and more tissue will just keep dying, and then you will need to have an amputation.
Just compromising the healthy tissue underneath.
Yes. Well,
Would we
what
know?
are the medical diagnoses? You will know by looking at the wound. Okay, just a few different terminologies. You have to know all of these because it comes up on the board. An abrasion is a scrape. Contusion is a bruise. Hematoma indicates a break in a blood vessel underneath the skin. And a laceration is a cut. Penetrating wound is a wound that enters into the interior of an organ or a cavity, like a stab wound.
What was the hematoma?
Break in a blood vessel. So essentially like a super large bruise. I ate a cookie in my pocket.
Yeah.
Okay, a puncture wound, again, is something sharp and pointed that penetrates through the skin. So it's similar to a penetrating wound, it just doesn't go as deep. Dropped a pair of, what are those, like cuticle cutters? And it like went straight through my thigh. Okay, so again, just reviewing what the different type of tissues look like, because you will have to be able to identify them in pictures. Granulation is beefy red, bumpy, usually shiny. It's a good thing. epithelial tissue. So you'll see at the edges, it'll be usually some sort of pink color. So paler in color than granulation, and it's going to be at the borders, and it's a good sign. It means the epithelium is being regrown. Slough is a soft yellow necrotic tissue. Eschar is thick, hard, leathery, very dry. Macerated is white and will be at the peri-root. Okay, the different types of drainage. Again, you have to know what they look like and what they indicate. So number one, we have serous. Clear, light, thin, watery. So if you've ever popped a blister, that was serous exudate. Sanguineous, bloody. So it's thin but red, still watery, and either means that there's some bleeding or that new vessels are being made. Seros sanguineous is a mix of the first two, so it's going to be very light red or pink, still thin and watery. And still not a bad thing. Purulent is the bad one. This is where it's creamy, opaque, thick, yellow, green, maybe white or tan, and it indicates infection. Not good. So thicker, more opaque, yellow or green. Green is definitely not a good one. It's usually smelly too. Okay, there's 4 different types of ulcers that you have to know about. We're going to talk about pressure ulcers, which you already know a little bit about. We're going to go through all the different vascular ulcers that can result because of the circulation issues. Then we have what are called neuropathic ulcers, which are secondary to diabetes. And last but not least, malignant wounds, which are secondary to cancer. A very bad sign and usually seen in terminal patients. Okay, so what causes a pressure ulcer?
Too much chilling.
Too much pressure, not enough movement. Where are these going to be located?
That's what I was talking about earlier.
Bony prominences. You can also have friction and shearing forces, not just compression, over those bony prominences. And I would argue the number one cause is immobility. Okay, but there's a whole bunch of risk factors for developing a pressure ulcer. I believe I included another chart on this in that little PDF document. The older you get, the skin is thinner. There's less collagen and elastin. There's actually also less subcutaneous fat. Okay, so as we age, more of our fat actually moves internally. So it's another reason the skin doesn't bounce back as well. Immobility. If you don't move and stay in one position, things will degrade. Incontinence. Why? Moisture.
And bacteria.
And bacteria. If anyone has a systemic or localized infection, that will increase their risk of a pressure ulcer. Low blood pressure. Why is low blood pressure a risk factor for developing a pressure ulcer? Say that again? Not enough circulation, not enough blood to the skin. Malnutrition. One more that's not on here.
Diabetes?
Yes, diabetes, smoking. There's another one. Well, any sort of circulation issue. What else? What else do we have besides blood vessels?
Nerve.
Huh? I said it.
don't think it's right.
He said
Is it nerve?
Yeah.
So you got
I didn't have the
Matter.
nerve.
There's safe pressure.
Diminished
Makes sense.
sensation.
Makes sense.
Why is that gonna matter?
You're not
They
gonna
can't
know
feel
it.
it. They're not gonna move.
There's
Do
a-
anything about it.
There's a hole back there? What do you mean?
No, really, like you'll see these huge, crazy wounds, and you're like, how did that ever come to be? They can't feel it. Nail in the foot for days. They don't know. They literally cannot feel it, so they're an increased risk. Okay, so number one, treatment of pressure ulcers,
Rotation, movement. Relief of
prevent them.
positioning.
Prevent them in the first place, because once they're there, it's going to be hard to get them to heal. So again, what's number one treatment for pressure ulcers?
Prevention.
Prevention. How do we prevent pressure ulcers? Food.
Did you
If
want
not,
that?
you're educating the caregiver on positioning and how often they need to rotate the patient and get a better mattress or wheelchair cushion. Reduce friction and shearing forces, which means caregiver education on what? Transfers. I've done lots of home health visits where that's all I was doing. There was nothing I could do for the patient. I just had to teach the caregivers how to reposition and transfer them.
Charge a lot of money.
Well, I don't charge a lot of money though.
Home health company does.
Yeah.
It's under Medicare Part A, so essentially it's where you get paid under Medicare Part B. That's all fun stuff you get to learn in your last term. If they have a chronic illness, they need to control it, maximize their nutritional status, and manage moisture. Okay, so with pressure ulcers, it's going to be true for all of their wounds. You're going to measure the length and the width. Length is always cranial to caudal. Width is always medial lateral. You always use centimeters. You're going to describe the amount of exudate after removing the dressing. So it would be none, light, moderate, or heavy. Write that down. None, light, moderate, or heavy.
You were thinking the same thing?
And then you're also going to describe what type of exudate it is. What are our options? Serous, serous, sanguineous,
Sangria?
or purulent. Okay, then we'll describe the type of tissue that is present, whether it's just granulation tissue, if there's slough or necrotic tissue present. And you're actually never going to describe it as healed if there's